lungs. Introduction: the lungs, occupying major portions of the thoracic cavity, leave little space for the heart, which excavates more of the left limb. The two lungs hold the heart tight between them, providing it the protection it rightly deserves. There are 10 bronchopulmonary segments in each lung. The lungs are a pair of respiratory organs situated in the thoracic cavity. Each lung invaginates the corresponding pleural cavity. The right and left lungs are separated by the mediastinum. The lungs are spongy in texture. In the young, the lungs are brown or gray in color. Gradually, they become mottled black because of the deposition of inhaled carbon particles. The right lung weighs about 700 g, it is about 50 to 100 g heavier than the left lung. Lungs dissection. Identify the lungs by the thin anterior border, thick posterior border, conical apex, wider base, medial surface with hilum and costal surface with impressions of the ribs and intercostal spaces. In addition, the right lung is distinguished by the presence of 3 lobes, whereas left lung comprises 2 lobes only. On the mediastinal part of the medial surface of right lung, identify 2 bronchi: the eparterial and hyparterial bronchi, with bronchial vessels, and posterior pulmonary plexus, the pulmonary artery between the 2 bronchi on an anterior plane. The upper pulmonary vein is situated still on an anterior plane, while the lower pulmonary vein is identified below the bronchi. The impressions on the right lung are of superior vena cava, inferior vena cava, right ventricle. Behind the root of lung are the impressions of vena azygos and esophagus. Hilum of the left lung shows the single bronchus situated posteriorly, with bronchial vessels and posterior pulmonary plexus. The pulmonary artery lies above the bronchus. Anterior to the bronchus is the upper pulmonary vein, while the lower vein lies below the bronchus. The mediastinal surface of left lung has the impression of left ventricle, ascending aorta. Behind the root of the left lung are the impressions of descending thoracic aorta, while esophagus leaves an impression in the lower part only. Features: each lung is conical in shape, Fig 16.1. It has an apex at the upper end. 2 base resting on the diaphragm. 3 borders, i.e. anterior, posterior and inferior. 2 surfaces, i.e. costal and medial. The medial surface is divided into vertebral and mediastinal parts. The apex is blunt and lies above the level of the anterior end of the first rib. It reaches nearly 2.5 centimeters above the medial 1/3 of the clavicle, just medial to the supraclavicular fossa. 2 is covered by the cervical pleura and by the suprapleural membrane, and is grooved by the subclavian artery on the medial side and anteriorly. The base is semilunar and concave. It rests on the diaphragm, which separates the right lung from the right lobe of the liver, and the left lung from the left lobe of the liver, the fundus of the stomach, and the spleen. The anterior border is very thin, Fig 16.2 and 16.3. It is shorter than the posterior border. On the right side, IL is vertical and corresponds to the anterior or costa-mediastinal line of pleural reflection. The anterior border of the left lung shows a wide cardiac notch below the level of the 4th costal cartilage. The heart and pericardium are not covered by the lung in the region of this notch. The posterior border is thick and ill-defined. It corresponds to the medial margins of the heads of the ribs. It extends from the level of the 7th cervical spine to the 10th thoracic spine. The error border separates the base from the costal and medial surfaces. The costal sacrophos is large and convex. It is in contact with the costal pleura and the overlying thoracic wall. The medial surface is divided into a posterior or vertebral part, and an anterior or mediastinal part. The vertebral part is related to the vertebral bodies, intervertebral discs, the posterior intercostal vessels and the splanchnic nerves, see Figs 15.1 and 15.2. The mediastinal part is related to the mediastinal septum, and shows a cardiac impression, the hilum, and a number of other impressions which differ on the 2 sides. Various relations of the mediastinal surfaces of the T-bro lungs are listed in Table 16.1. Fissures and lobes of the lungs. The right lung is divided into 3 lobes, upper, middle, and lower, by two fissures, oblique and horizontal. The left lung is divided into two lobes by the oblique fissure, Fig 16.1. The oblique fissure cuts into the whole thickness of the lung, except at the hilum. It passes obliquely downwards and forwards, crossing the posterior border about 6 cm below the apex and the inferior border about 5 cm from the median plane. Due to the oblique plane of the fissure, the lower lobe is more posterior and the upper and middle lobe more anterior. In the right lung, the horizontal fissure passes from the anterior border up to the oblique fissure and separates a wedge-shaped middle lobe from the upper lobe. The fissure runs horizontally at the level of the fourth costal cartilage and meets the oblique fissure in the mid-axillary line. The tongue-shaped projection of the left lung below the cardiac notch is called the /inked IA. It corresponds to the middle lobe of the right lung. The lungs expand maximally in the inferior direction because movements of the thoracic wall and diaphragm are maximal towards the base of the lung. The presence of the oblique fissure of each lung allows a more uniform expansion of the whole lung. Surface marking of the lung/visceral pleura. The apex of the lung coincides with the cervical pleura, and is represented by a line convex upwards rising 2.5 cm above the medial 1/3 of the clavicle, see Fig 21.2. The anterior border of the right lung corresponds very closely to the anterior margin or costa-mediastinal line of the pleura and is obtained by joining, a point at the sternoclavicular joint, a point in the median plane at the sternal angle, a point in the median plane just above the xiphisternal joint. The anterior border of the limg corresponds to the anterior margin of the pleura up to the level of the fourth costal cartilage. In the lower part, it presents a cardiac notch of variable size. From the level of the fourth costal cartilage, it passes laterally for 3.5 cm from the sternal margin, and then curves downwards and medially to reach the sixth costal cartilage 4 cm from the median plane. In the region of the cardiac notch, the pericardium is covered only by a double layer of pleura. The area of the cardiac notch is dull on percussion and is called the area of superficial cardiac dullness. The lower border of each lung lies 2 ribs higher than the pleural reflection. It crosses the 6th rib in the midclavicular line, the 8th rib in the mid-axillary line, the 10th rib at the lateral border of the erector spinae, and ends 2 cm lateral to the 10th thoracic spine. The posterior border coincides with the posterior margin of the pleural reflection except that its lower end lies at the level of the 10th thoracic spine. The oblique fissure can be drawn by joining, a point 2 cm lateral to the 3rd thoracic spine. Another point on the 5th rib in the mid-axillary line. A third point on the 6th costal cartilage 7.5 cm from the median plane. The horizontal fissure is represented by a line joining, a point on the anterior border of the right lung at the level of the 4th costal cartilage. A second point on the 5th rib in the mid-axillary line. Root of the lung is a short, broad pedicle which connects the medial surface of the lung to the mediastinum. It is formed by structures which either enter or come out of the lung at the hilum, Latin depression. The roots of the lungs lie opposite the bodies of the 5th, 6th, and 7th thoracic vertebrae. Uroinfants. The root is made up of the following structures. 1 principal bronchus on the left side, and eparterial and hyparterial bronchi on the right side. 2. 1 pulmonary artery. 3. 2 pulmonary veins, superior and inferior. 4 bronchial arteries, 1 on the right side and 2 on the left side. 5 bronchial veins. 6 anterior and posterior pulmonary plex uses of nerves. 7 lymphatics of the lung. 8 bronchopulmonary lymph nodes. 9 areolar tissue. Arrangement of structures in the root. 1 from anterior to posterior. It is similar on the two sides, Fig 16.4. Superior pulmonary vein, pulmonary artery, bronchus. 2 from above downwards. It is different on the two sides. Right side eparterial bronchus, pulmonary artery, hyparterial bronchus, inferior pulmonary vein. Left side pulmonary artery, bronchus, inferior pulmonary vein. Relations at the root. Anterior. 1 common on the two sides, phrenic nerve, pericardiaco-phrenic vessels, anterior pulmonary plexus. 2 on the right side, superior vena cava, Fig 16.2, a part of the right atrium. Lose terror 1, dent mon cove f/ie sides, vagus nerve posterior pulmonary plexus le side, descending thoracic aorta 1 atrive / terminal part of esophagus vein 2 out /e / stde, arch of the aorta. Pulmonary ligament. Differences between the right and left lungs. These are given in table 16.2. Arterial supply. The bronchial arteries supply nutrition to the bronchial tree and to the pulmonary tissue. These are small arteries that vary in number, size, and origin, but usually they are as follows. L. On the right side, there is one bronchial artery which arises from the third right posterior intercostal artery. 2. On the left side, there are two bronchial arteries, both of which arise from the descending thoracic aorta, the upper opposite left thoracic vertebra and the lower just below the left bronchus. Deoxygenated blood is brought to the lungs by the two pulmonary arteries, and oxygenated blood is returned to the heart by the four pulmonary veins. There are precapillary anastomoses between bronchial and pulmonary arteries. These connections enlarge when any one of them is obstructed in disease. Venous drainage of the lungs. The venous blood from the first and second divisions of the bronchi is carried by bronchial veins. Usually there are two bronchial veins on each side. The right bronchial veins drain into the azygous vein. The left bronchial veins drain into the hemiazygos vein. The greater part of the venous blood from the lungs is drained by the pulmonary veins. Lymphatic drainage. There are two sets of lymphatics, both of which drain into the bronchopulmonary nodes. One superficial vessels drain the peripheral lung tissue lying beneath the pulmonary pleura. The vessels pass round the borders of the lung and margins of the fissures to reach the hilum. Two deep lymphatics drain the bronchial tree, the pulmonary vessels and the connective tissue septa. They run towards the hilum where they drain into the bronchopulmonary nodes, Fig 16.4. The superficial vessels have numerous valves and the deep vessels have only a few valves or no valves at all. Though there is no free anastomosis between the superficial and deep vessels, some connections exist which can open up, so that lymph can flow from the deep to the superficial lymphatics when the deep vessels are obstructed in disease of the lungs or of the lymph nodes. Nerve supply. 1. Parasympathetic nerves are derived from the vagus. These fibers are motor to the bronchial muscles, and on stimulation cause bronchospasm. Secretomotor to the mucous glands of the bronchial tree. Sensory fibers are responsible for the stretch reflex of the lungs, and for the cough reflex. 2. Sympathetic nerves are derived from second to fifth sympathetic ganglia. These are inhibitory to the smooth muscle and glands of the bronchial tree. That is, show sympathomimetic drugs, like adrenaline, cause bronchodilation and relieve symptoms of bronchial asthma. Both parasympathetic and sympathetic nerves first form anterior and posterior pulmonary plexuses situated in front of and behind the lung roots. From the plexuses nerves are distributed to the lungs along the blood vessels and bronchi, Fig 16.4. Dissection. Dissect the principal bronchus into the left lung. Remove the pulmonary tissue and follow the main bronchus till it is seen to divide into two lobar bronchi. Try to dissect till these divide into the segmental bronchi. Dissect the principal bronchus into the right lung. Remove the pulmonary tissue and follow the main bronchus till it is seen to divide into three lobar bronchi. Try to dissect till these divide into segmental bronchi. Bronchial tree. The trachea divides at the level of the lower border of the fourth thoracic vertebra into two primary principal bronchi, one for each lung. The right principal bronchus is 2.5 cm long. It is shorter, wider, and more in line with the trachea than the left principal bronchus, Fig 16.5. Inhaled particles or foreign bodies therefore, tend to pass more frequently to the right lung, with the result that infections are more common on the right side than on the left. The left principal bronchus is 5 cm. It is longer, narrower and more oblique than the right bronchus. Right bronchus makes an angle of 25 degrees with tracheal bifurcation, while left bronchus makes an angle of 45 degrees with the trachea. Each principal bronchus enters the lung through the hilum, and divides into secondary lobar bronchi, one for each lobe of the lungs. Thus there are 3 lobar bronchi on the right side, and only 2 on the left side. Each lobar bronchus divides into tertiary or segmental bronchi, one for each bronchopulmonary segment, which are 10 on the right side and 10 on the left side. The segmental bronchi divide repeatedly to form very small branches called terminal horizontales. Still smaller branches are called respiratory bronchioles, Fig 16.6. Each respiratory bronchiole aerates a small part of the lung known as a pulmonary unit. The respiratory bronchiole ends in microscopic passages which are termed 1 alveolar ducts, Fig 16.7, 2 atria, 3 air saccules, 4 pulmonary alveoli, Latin small cavity. Gaseous exchanges take place in the alveoli. Bronchopulmonary segments. The most widely accepted classification of segments is given in Table 16.3. There are 10 segments on the right side and 10 on the left, Fig 16.5 and 16.8. Definition 1. These are well-defined anatomic, functional, and surgical sectors of the lung. 2. Each one is aerated by a tertiary or segmental bronchus. 3. Each segment is pyramidal in shape with its apex directed towards the root of the lung, Fig 16.8. 4. Each segment has a segmental bronchus, segmental artery, autonomic nerves, and lymph vessels. 5. The segmental venules lies in the connective tissue between adjacent pulmonary units of bronchopulmonary segments. 6. During segmental resection, the surgeon works along the segmental veins to isolate a particular segment. Relation to pulmonary artery. The branches of the pulmonary artery accompany the bronchi. The artery lies dorsolateral to the bronchus. Thus each segment has its own separate artery, Fig 16.9. Relation to pulmonary vein. 4. Pulmonary veins do not accompany the bronchi or pulmonary arteries. They run in the intersegmental planes. Thus each segment has more than one vein and each vein drains more than one segment. Near the hilum the veins are ventromedial to the bronchus. It should be noted that the bronchopulmonary segment is not a bronchovascular segment because it does not have its own vein. Usually the infection of a bronchopulmonary segment remains restricted to it, although tuberculosis and bronchogenic carcinoma may spread from one segment to another. Knowledge of the detailed anatomy of the bronchial tree helps considerably in segmental resection, Fig 16.10. Visualizing the interior of the bronchi through an instrument passed through the mouth and trachea. The instrument is called a bronchoscope and the procedure is called bronchoscopy. Carina is the area where trachea divides into two primary bronchi. Right bronchus makes an angle of 25 degrees, while left one makes an angle of 45 degrees. Foreign bodies mostly descend into right bronchus, Fig 16.11, as it is wider and more vertical than the left bronchus. Carina, Latin keel, of the trachea is a sensitive area. When patient is made to lie on her/his left side, secretions from right bronchial tree flow towards the carina due to effect of gravity. This stimulates the cough reflex and sputum is brought out. This is called posterior drainage, Fig 16.12. Clinical anatomy. Paradoxical respiration. During inspiration the flail, abnormally mobile, segment of ribs are pulled inside the chest wall while during expiration the ribs are pushed out, Fig 16.13. Tuberculosis of lung is one of the commonest diseases. A complete course of treatment must be taken under the guidance of a physician. Bronchial OSF/IMO is a common disease of respiratory system. It occurs due to bronchospasm O1 smooth muscles in the wall of bronchioles. Patient has difficulty especially during expiration. It is accompanied by wheezing. Epinephrine, a sympathomimetic drug, relieves the symptoms. Auscultation of lung. Upper lobe is auscultated above fourth rib on both sides, lower lobes are best heard on the back. Middle lobe is auscultated between fourth and sixth ribs on right side. Apical segment of lower lobe is the most dependent bronchopulmonary segment in supine position. Foreign bodies are likely to be lodged. Large spongy lungs occupy almost whole of thoracic cage, leaving little space for the heart and accompanying blood vessels, etc. Bronchopulmonary segments are independent functional units of lung. Lungs are subjected to lot of insult by the smoke of cigarette/bidi/pollution. Tuberculosis of lung is one of the commonest killer in an underdeveloped or a developing country. Complete treatment of TB is a must, otherwise the bacteria become resistant to antitubercular treatment.